All right. I think we can probably get started. Thank you all for coming today to our first Common Sense Oncology Journal Club of 2025, Illuminating the Data, a critical look at the STARGLO trial and the SWOG trial for Hodgkin lymphoma. We have several experts in hematology with us today to talk about these two studies. Aaron Goodman might be joining us later. I think he's on a taco adventure in Iowa right now. Tyso Phillips is here. He's a hematologist from City of Hope Cancer Center. We have Anthony Personati, a clinical pharmacist from the University of Michigan. And we have Manju Sengar, a medical oncologist and professor from the Tata Memorial Hospital in Mumbai. So thanks to the experts for joining us and for the audience for coming here today. A little bit of an outline of what we're going to cover today. We're going to start with a very short CSO reminder and some updates, and then we'll dive right into the journal club and have our experts discuss the trials. And finally, we'll leave some questions for the audience to participate and ask some questions. As a reminder, Common Sense Oncology is a grassroots movement with the mission of ensuring that cancer care focuses on outcomes that matter to our patients. We want our patients to live longer and live better. And to achieve this mission, our vision is that patients have access to cancer treatments that provide meaningful improvements in outcomes that matter irrespective of where they live or what medical system they're in. And everybody can get involved in the CSO movement. I've included a link there to join and get started for free. So as a reminder, the work that CSO does really falls into three main buckets in improving evidence generation, evidence interpretation, and evidence communication. And the journal club we're going to go through today really focuses on the evidence interpretation piece of this. Before we start, though, and dive into the journal club, I wanted to highlight the recent work from the clinical trials work group, who published a series of principles aimed at improving the design, analysis, and reporting of phase 3 randomized controlled trials used to evaluate cancer treatments. They also included a very helpful checklist and some figures, and we're going to use some of those today when we go through the paper and help guide our discussion. So with that out of the way, I wanted to remind us all of the Journal Club series that will occur approximately monthly. So we're going to have Journal Club critical appraisals just like this, as well as patient panels, workshops, and several special topics. So make sure to follow us on social media and then sign up for free at commonsenseoncology.org. And now we will turn it over to our expert, Tyso Phillips, who will walk us through the STARGLO study. Take it away, Tyso.
All right, thank you. And thanks everybody for joining. And so we will discuss STARGLO, but after we go through this initial page, we'll do some level setting just to sort of get everybody sort of calibrated to where we are with the field. So as we all know, relapsed refractory large cell lymphoma is a very difficult to treat patient population. I think no more highlighted than in the study that compared, the initial PARMA study, which compared salvage therapy to salvage with auto transplant. Again, most of the patients with response in this patient population were those with relapsed disease versus primary refractory. And so I do think it took quite a bit of while before we had a true sort of idea of how poorly patients who have refractory disease actually perform in some of these salvage settings, especially with continuous chemoimmunotherapy. So if we go to the next slide, if we look at the CORAL study, which compared RICE to RDHAP in this patient population, again, if we look at the patient population with patients with prior rituximab, yes or no, obviously in this situation, patients who were previously exposed to rituximab have very poor outcomes in this patient population. I'll bet this was right around the time, again, when rituximab was introduced into the clinical market. If we go to the next slide, with that, in the initial SCHOLAR-1 data, we saw how poorly refractory patients did in this patient population, which led to the development of CAR T-cell therapy, especially in the third-line setting. Because of the benefit of CAR T-cell therapy in this third-line setting, we did have several randomized trials in the second-line space. 2 of the 3 studies actually showed a progression-free survival benefit. ZUMA-7, which was with the axi-cell product, actually showed an overall survival benefit. Some discrepancies between the trial. Obviously, Axicell had no bridging, no crossover in that patient population. Well, Lysocell did allow for bridging, did have crossover, and so it may have muted some of the survival benefit in this patient population. Both studies with more updated sort of evaluation did sort of indicate, even in this situation, that even patients with autologous response to chemotherapy that went to the standard of care arm still did not necessarily have the same benefit as the patients who proceeded to CAR T cell therapy in the second line space. But as we all know, CAR T cell therapy is not available worldwide. There's obviously limitations to medical resources. The manufacturing can sometimes be an issue. Patients have to relocate from their homes for a period of time, usually 30 days, has to have a caregiver. So logistically, there's also some issues there. And then again, sometimes the disease itself does not allow for a patient to get to CAR T cell therapy. So in that sense, there's always room for improvement. And while we will probably never get a study randomized directly against CAR T cell therapy, there are some ways to sort of circumvent this and try to evaluate the benefit of certain agents in the second line space. Next slide. And so with this is just sort of how a US perspective of how we look at primary refractory patients, again, with CAR T cell therapy being a sort of pivotal sort of point there. There's really not a such thing as ineligible for CAR T for the most part. Those ineligible for CAR T are generally almost ineligible for other treatments, but for sake of just transparency, we do include that there. If we go to the next slide. And then again, if we look at relapsed refractory patients globally, there's still a high utilization of salvage chemotherapy and autologous stem cell transplantation, even in refractory patients, again, going to the limitations and the reach of CAR T cell therapy globally. Next slide, please. And so with that, that gives us sort of leeway to the STARGLO study. So STARGLO is evaluating the addition of glofitamab, which is a CD20, CD3 bispecific antibody, together with GemOx, which is a heavily utilized chemotherapy regimen worldwide. Ideally, in this situation, very similar to R-GDP, which is heavily utilized in Canada. And in some situations, has been the substitution of oxaliplatin for cisplatin due to some of the toxicities we see with cisplatin, such as auditory toxicity and neuropathy, which are much, much less frequently in oxaliplatin. And at least unlike what we see with carboplatin, there's equivalency with oxaliplatin compared to cisplatin in this patient population. And so in this study, patients were able to receive GloFit GemOx for cycles 1 through 8. Glofitamab was given in a step-up dosing, as we typically see. So it starts with 2.5 milligrams, 10 milligrams, and 30 milligrams. This is typically preceded by a infusion of obinutuzumab of 1,000 milligrams the week prior. In this situation, because of the concordance of using GemOx in this situation, which is cytoreduction, again, you could possibly mitigate the use of the obinutuzumab in this patient population. These patients were randomized in a 2-to-1 fashion to receive our GemOx as standard of care. And then after cycle 8, the patients had the option of receiving 3 additional cycles of glofitamab, in essence, to complete the 12 cycles that we typically would give in a third-line setting where this is currently approved in the US. Next slide, please. So the primary endpoint for STARGLO was progression-free survival by independent review committee. Overall survival with secondary endpoints of progression-free survival, complete response rate, and duration of complete response. They had a pre-planned primary analysis at the 70% of the overall survival events with approximately 101 patients enrolled. This occurred in March of 2023. And then they had an updated analysis in February 16, 2024, with an overall survival of median overall survival of 20.7 months. Next slide. So looking at baseline characteristics, fairly equivalent between the two arms. There is some diversity in ethnicity, as you see, about half the patients in the R-GemOx arm or have Asian descent, 47% in GloFit GemOx. Very few African-American or Black patients, about a third of patients, up to a little bit less than 50%, were white or Caucasian. ECOG performance status, fairly equal if you combine 1 and 0 and 1. Most patients had advanced stage disease. Median prior lines of therapy were equal, whether a patient was considered to be primary refractory, about equal between the two arms. Refractory last therapy, and if these patients had received prior CAR T cell therapy, see very few of them had in this study. Next slide. And so overall, obviously, if we're presenting this, the study did meet its primary endpoint. So there was considered to be an overall survival benefit with the addition of glofitamab to GemOx in this patient population compared to ARM GemOx with a hazard ratio of 0.59. Even with the updated analysis, you have an overall survival benefit of 25.5 months versus 12.9 months. Again, with a hazard ratio of 0.62, both, which is statistically significant at 0.006. The 24-month overall survival is 33.5% versus 52.8%. Next slide, please. PFS, again, substantial benefit with 12.1 months versus 3.3. With the updated analysis, we have 13.8 versus 3.6, hazard ratio of 0.37, updated to 0.4, again, statistically significant, and 12-month PFS, again, favoring glofit GemOx. Next slide. Overall response rate and complete response rate, again, favoring glofit GemOx, which fits with what we see with the overall survival, progression-free survival. Next slide. And again, if we look at subgroup analysis, which we're all, remiss to do, but I think we all take some enjoyment at looking at some of the subgroups. I will point out the key sort of concern with this study would be just the very limited number of patients enrolled in North America, as well as the limited number of patients enrolled in Europe. And obviously, if you can see the confidence intervals, they both span one in this situation with Europe and North American patients. Again, so calling into question with at least some regionality bias in this study. But again, small numbers, hard to make conclusive ideas and discussions from this. But beyond that, most of the other subsets tend to favor glofit GemOx in this patient population. So if we go to the next slide. Safety profile, which is highly important given we're given a bispecific antibody. For the most part, adverse events were seen in majority of all patients in both arms. Serious adverse events, there was more in the glofit GemOx arm, 54.4% versus 17%. Majority of these were considered to be related to glofitamab in the glofit GemOx arm, with grade 3 to 5 AEs, again, 77.8% versus 40.9%. A little less than half, again, associated with glofitamab in this patient population. And again, 5 fatal adverse events versus 1 in this situation, again, majority favoring glofitamab. Neutropenia, anemia, neuropathy, transaminitis, and serious infection, again, all at higher rates in glofit and GemOx in this patient population. So looking at CRS here sort of mirrors what we would expect to see with glofitamab as a single agent diffuse large B-cell lymphoma, so it did not look like there was a substantial increase in the incidence, severity, or duration of CRS. Majority of the CRS was with the first dose, which we would typically expect. Most are grade 1, grade 2, very few, if any, grade 3 episodes of cytokine release syndrome. Tocilizumab was used in about 36.8% of patients, and about half the patients got corticosteroids. Next slide. Looking at other adverse events, so there was 4 episodes of ICANS, which is immune effector cell associated neurological syndrome. 1 was considered grade 3 or above. Again, in this situation, quite a few things are considered neurological toxicity in this patient population, whether this is true ICANS or not, as what we think with CAR-T is a little bit difficult to determine. Infections, 57.2%, neutropenia, 42.2%, a third of which were grade 3 or above. And again, febrile neutropenia favors our GemOx with 1 versus 6 with glofit GemOx. As we all learned during the COVID pandemic, bispecifics and COVID-19 do not mix very well. Obviously, as you see in this study, there's no different. So high rates of COVID-19 infection and death compared to the R-GemOx arm, which again speaks to the high depletion of B cells and the T cell sort of distraction with bispecifics in this patient population. Next slide. So the conclusion with this is that glofit added to GemOx and had a overall survival benefit and progression-free survival benefit in his patient population with relapsed refractory diffuse large B-cell lymphoma. This was fairly well tolerable and consistent for the most part with what we see with glofit alone. Obviously, adding glofitamab to a chemotherapy regimen such as GemOx can also increase the toxicity, which we see indicated in neutropenia and some of the infection risks. But overall, this demonstrated some benefit of this combination, especially in patients with second-line large cell lymphoma, and does provide sort of a backdoor avenue of trying to get this regimen into the second-line setting versus conventionally what we would expect to see a randomized trial against CAR T-cell therapy. And I think that concludes everything for us.
All right, so thanks, Tyson. On the surface, this study looks like a very well conducted study. And I think a lot of randomized controlled trials that we all read on the surface always look like they're excellent studies. And so the CSO group put together a very nice paper that was just published this past month that helps all of us clinicians critically appraise literature. These are all questions when we're reading all these randomized controlled trials. These are questions that we should ask ourselves. And it will help us, for the most part, figure out if the data clinically apply to our patient population. So we're going to spend some time here as a panel, and the audience is more than welcome to jump in as well. We'll go through this CSO tool to show you it. I think the questions are self-explanatory, but sometimes trying to come up with the answer is not always easy. So let's start off with the first question is, are patients in this trial representative of your clinical practice? So Taisal, I'll start with you and then we'll go to Manju. So Taisal, you're going to represent, North American practice. In your opinion, did this trial represent your clinical practice of how you would treat patients?
No. I mean, but obviously that's
No.
just because then we would not enroll refractory patients into a trial like this, unless very honestly, we planned if they were randomized to the standard of care arm to go directly to CAR T. So this wouldn't be otherwise patients that we would consider for this trial.
Yeah. How about you, Manju? And you're
Yes.
in
So,
India.
yeah, that's right. We do have now access to CAR-T, but it's not really universal as of now. So, for a lot of patients who fail first-line therapy, the option still remains salvage therapy followed by stem cell transplant, depending on how the response to that salvage therapy has been. So, yes, to a significant majority, that would be the choice that you would go for salvage and auto.
Great. Yeah, and obviously, we live in our ivory towers and, we have access to CAR T, but not everybody does. And so in some jurisdictions, this might actually represent the standard of care. The other population that I'll bring up that I don't think is representative is our DLBCL patients that are a bit more aggressive. Obviously, our double hits, high-grade lymphomas were not included, but even our regular DLBCLs, that are a bit more aggressive than the norm, where they're rapidly progressing. These are the patients that we get called about and they ask, hey, how do I rapidly up titrate glofitamab? How do I rapidly up titrate epcoritamab? And it's like, well, you probably shouldn't use that drug in a patient who's, rapidly progressing. The T cells are, no matter how fast you get up the target dose, it's still going to take some time. So that population is obviously not in a clinical trial like this. They often get neglected because you just don't have time to include them. And in our practice, that's probably about 20 or so% of the population. So the next question is the surrogate endpoint used? If a surrogate endpoint is used, does it predict overall survival or quality of life? This one's an easy one, and you have to commend the authors and the investigators. Overall survival was chosen. So then the next question would be, is the trial designed to detect or rule out substantial clinical benefit? Bernie, I don't know if you want to jump in here to talk a little bit about this.
Yeah, I think the trial was the fact that they designed it for overall survival. I think this was a well-intentioned trial in terms of assessing the right endpoints. They also assessed quality of life, which these results aren't reported yet, but they will be in the future. So I think those are both positive aspects of this trial that I think are extremely beneficial. So those things I think are key. But I think the biggest piece is kind of what Tyson mentioned earlier. There are very few patients who are not either CAR T eligible right now. And so for our practice, while these patients were, ineligible or they were unfit patients, they were relatively fit when you look at the patients that were enrolled in this study. They kind of fit more of our probably auto eligible patients when you look at the baseline characteristics.
Yeah, and the other piece about the trial design and whether or not it could rule out substantial clinical benefit. The other thing that you should keep in mind, they did a good job in this study. So they had an interim analysis, and they do some adjustments in the p-value, either for multiple looks or early looks. Some studies don't do that. And so you could end up with a type 1 error where there's a false positive, meaning that there's a false indication that there is a difference when there wasn't a difference. And so this study really brought down their p-value. They did some statistical adjustments. They did a very good job. There was a recent, and I'm not going to get into it, a recent myeloma trial where there was a very questionable improvement in overall survival. And, there was no adjustments for multiple looks. And that could be a reason for an overall survival benefit being shown when in reality there isn't one. So, take a look at when there are early looks or multiple looks at overall survival, are they statistically adjusting for that? What else? The control arm, we talked about this. It likely would be a CAR T censoring.
What do you think about the censoring?
Yeah, Bernie, can you go back to the survival curve?
Sure.
I think censoring is by far one of the hardest things for any of us to really assess for two reasons. One is that most journals are not transparent about how many patients are actually censored. So like you can look at the survival curve here, and obviously every tick equals a censored patient. Well, like I cannot see every single tick on this line, on this Kaplan-Meier curve. So like I would just be wrong half the time when I'm trying to figure this out. But what good journals like Lancet will do, New England Journal of Medicine does not do this. But what good journals will do is at the bottom here where Bernie's pointing is that it'll show you how many patients were censored. And the second reason why it's super hard to really assess is we often don't have the transparency of knowing why patients were censored. And understanding why a patient fell off is super important, because obviously if a patient fell off because they didn't show up for their scan because they were doing well, that's a very different patient than a patient that got censored because of toxicity, or a patient who got censored who realized, oh wait, I didn't get glofitamab. I don't want Gemox. That's probably a very fit, very wealthy patient that's like, well, I'm just going to leave this clinical trial and go somewhere else and get CAR T, or I'll go get another therapy because I wanted GlowFit. So most trials are not very transparent, so it is very hard. And even if you did know the answer, how to fully understand how that impacts your results is also very, very difficult too. So this is, what probably need even more guidance from CSO of exactly how to tell journals and guide journals to help us with the censoring. But long story short, when you look at the censoring here at 3 months, it looks like 6 patients and 9 patients were censored. And so on the surface, you're like, oh, it's equal censoring between the two groups. But you have to remember, this was a 2-to-1 randomization. So there should actually be double the amount of censoring in the GlowFit if it was equal. And therefore, you're actually censoring double the amount of patients. You're having double the amount of early censoring in this study in the R-GemOx. So this is probably patients that were like, oh crap, I don't want R-GemOx. I wanted GlowFit. I'm out of here. And so that's when you look at it, there's about 10% of patients were censored right off the bat. Now, in a study like this, where your overall survival benefit is massive, how much does the censoring actually impact that? Probably not a lot. But when your overall survival is, teeny tiny amount difference, that could actually dramatically change. Furthermore, when people are trying to do cost-effective analysis, obviously places outside of the United States where they care about drug costs, when you're doing cost-effective analyses, this could be the deciding factor of, wow, there was a massive magnitude in overall survival. It's cost effective versus, no, wait, hold on. The more and more you get into the details, the more to censor, those curves come in closer and closer together, and it's no longer cost effective. So that's my little rant on censoring, just because I think it's one of the most challenging ways to critically appraise literature. Okay,
I think
the next question. go ahead, Bernie.
No, I was going to say, I think the next question you're probably going to talk about is what these patients get on relapse, right?
Mm-hmm.
So I think if you're trying to move up a therapy like a bispecific in care, so if you're trying to add it to chemotherapy, the patients in the standard of care arm should get bispecifics on relapse.
Absolutely. And so then you have to ask yourself, well, how many patients in the GEMOX group was crossed over? Obviously, crossover was not allowed, which it should have been. But how many patients ended up receiving a bispecific that relapsed? Bernie, what were the numbers roughly?
So overall of the RGEMX arm, about 16% got bispecifics on relapse.
That's pretty
Now
lousy.
that's the total N of our GEMOX. So the true number is around 20 to 25% of patients who receive subsequent anti-lymphoma therapy.
Yeah, so that's not great. I don't, Bernie, in your CSO paper, do you guys come out and say, hey, this is an acceptable amount of crossover that should occur? Like when I think of a study, like I would love to see at least 70-ish% of patients that have relapsed get an effective therapy on relapse. But I don't know if you
Yeah.
guys came out and actually said how much should we ask for? Obviously,
think that
20%
yeah,
is terrible.
I think just one quick point, and then Manju has a great point. I think um, there's no specific amount called out, right? But if a therapy improves survival in a later line and you're trying to move it to an earlier line, that therapy should be provided by the sponsor and crossover should be mandated. However, the difficulty here is the bispecific data is just single arm phase 1, phase 2 data that led to approval. And so we all use it in the relapse refractory setting, in the third line setting, without a randomized controlled trial proving that it improves survival. So there's a bit of a disconnect there, and it has to do with sort of the landscape of approval of bispecifics in North America and the US. But Manju, what is your take on this? What?
No, I agree with you. I was pretty happy to see the distribution of patients from different regions, and it's
Mhm.
little unusual that you see more than 50% outside US and Europe coming in. So which was like a good part, and I was really happy to see that. But at the same time, I think that decided a lot in terms of what they got as post-progression therapy, because many of these patients probably did not have access to glofitamab, even though this
Mhm.
trial started in 2021 and the early phase trial which led to glofit approval as monotherapy was completed in 2021 and we had the approval. So but probably it wasn't marketed in these the countries where more than 50% patients came from, and that's probably the reason why you can see the difference, which is much more marked in that forest plot for countries other than US and other than the US and Europe patients. So I think a post-progression therapy, and as you rightly pointed out, that it probably becomes a moral responsibility to ensure that everyone has access to similar therapies once they finish the study, and that itself shouldn't be driving your entire result.
Completely agree. And I think conducting the study outside of the US where these drugs aren't approved shouldn't be justification for not providing it on relapse. Any final points before Tyso has his hand raised?
Yeah, I was going to say, I mean, I think unfortunately when these studies make overall survival their primary endpoint, it does incentivize them not to allow crossover because in essence, unfortunately, they are hoping to see what we see in these trials where patients are sort of succumbing to the disease in effort to get their approval in this situation. Because again, if the study only had a PFS benefit and not an overall survival benefit, I think you get a lot of criticism as well, even more so than what we already have for the trial in and of itself. So I think there's a lot of things to like about STARGLO, especially with the ability to sort of get an idea how it may impact other countries again, where we may not have access to bispecifics or CAR T cell therapy specifically, but I do think also on the same point, if all things being equal, you really wonder if this study would have had an overall survival benefit if these patients could have gotten other therapies like CAR T cell therapy or bispecifics at crossover, or even at
Yeah, I
relapse.
mean, you bring up a really good point, Teisel, and this is the issue that we have in the current landscape of clinical trials is we're asking questions for the pharmaceutical company and we're asking questions for the FDA to answer. But we are here to answer questions for patients. And the question that the patient wants to know is, do I need to use glofitamab in the third line setting as a single agent? Or should I move it up to frontline? And the only way to answer that is with crossover, because if there is no overall survival benefit, great. That means that I can use it in the third line setting. So, I think obviously our regulators need to be taught some of this, and we all just need to keep hounding them, and CSO needs to hound them to say, stop answering questions that are not helpful to tell us clinicians how to best treat patients.
That's well said. I think with that in mind, I think maybe we'll move on to Manju. Do you have a quick point?
Yeah, just
yes.
wanted to, just since I can understand that there are trainees here, many of them, is, looking at, if you look at the inclusion criteria, which says non-eligibility for autologous stem cell transplant, and if you read the, actual reason why they were non-eligible, 35% of them said they refused autologous stem cell transplant.
Mm-hmm.
To me, it's really not very acceptable that if they're eligible and refusing autologous stem cell transplant as being the reason. And a lot more moved out of therapy in the glofit arm because of toxicity. So there was significant, difference in terms of toxicity, more COVID deaths in this arm as compared to the GEMOX arm. So just to keep in mind when we're using these treatments in terms of, what gets in terms of toxicity data, how manageable it will be in your setting.
That's a great point. And it's something that we didn't really touch on. We focused mainly on the design of the trial, but I think the reporting of toxicities is crucial too. And we cover that a little bit in the paper too. We give some guidelines for reporting toxicities. A lot of the statements with regard to toxicity in the paper are the toxicities are what is expected of the individual drugs, not this arm was more toxic than this arm. So it was more of a, this is what we'd expect based on individual drugs. But not the combination is significantly more toxic than just giving two drugs. So I think that is a key point. We're going to move on to our next study, which I think answers a question that I think is very important for patients. So we'll turn it over to Teisel here.
All right. So we'll talk about SWOG 1826. So this study looks at Nivo AVD versus brentuximab AVD, sorry. And so just to level set this again, Hodgkin's lymphoma is a lot rarer than what we see with large cell lymphoma. In the US, about 1,200 deaths annually. Does have a bimodal sort of distribution, either young patients or patients typically a lot older. Risk factors we know, especially in older patients, EBV reactivation, HIV, or immunosuppression due to sort of stem cell transplantation, whether it be organ transplantation or stem cell transplantation. Next slide, please. And this just illustrates a bimodal peak, again, as we all would expect to see in our patients. Next slide. So there are 4 cases of classical Hodgkin's lymphoma. We did move out the one non-classical subtype. So we have nodosclerosing, which is the most common, mixed cellularity, lymphocyte rich, lymphocyte depleted, and the pathognomonic Reed-Sternberg cell, which is found rarely in most of the biopsies, surrounded by a lot of reactive immune cells in the tumor lymph node. The key thing is these tumor cells are 15 positive, 30 positive, and typically negative for CD20. Next slide. So we typically will treat differently for early stage patients, highly curative. I think we've moved away from maximizing cure to trying to maximize toxicity or minimizing toxicity in these early stage patients, as you see with several studies looking at eliminating radiation potentially or cutting back on a number of cycles of chemotherapy. With advanced stage, ideally, this patient population was ABVD for the longest. Europeans have used escalated BIACOP. More recently with Echelon, we saw brentuximab AVD have a PFS benefit, PFS2 initially, then a regular PFS benefit, and eventually an overall survival benefit. This unfortunately took several years. And I would say it's only been in the last 2 to 3 years that we would consider that the Echelon regimen to be the de facto standard of care for Hodgkin's lymphoma patients in the US. Next slide. So looking at prognostic factors for advanced stage patients, we have a Hazen-Cleaver score. You get penalized for older age, penalized for being a male, albumin, hemoglobin stage 4, white blood cell count, and lymphopenia, or absolute lymphocyte number as well. Next slide. And so for the most part, the argument had always been ABVD versus BIACOP, and this is just a dosing and a treatment regimens. The important things to think about ABVD was always more tolerable, and you could typically salvage patients, whereas escalated BIACOP had a lot of toxicities and scared of sterility in younger patients. And so, again, much frowned upon in the US, but in some situations, there may have been a role for escalated BIACOP in certain patients with high-risk features. Again, when we mentioned with Echelon sort of eliminated sort of the role of ABVD. I think people were very happy in some ways to get away from bleomycin. But with the Rathel method, there was some controversy that if you could eliminate the bleomycin, was there really a benefit over the Echelon method, especially with the PFS2? Again, with the initial PFS benefit, sort of less of a pushback, and then with an overall survival benefit, most clinicians considered Echelon to be the standard of care, even though there was some argument about the survival benefit in this patient population. In Europe and Germany, still escalated BIACOP was still the preferred treatment regimen for patients with advanced stage disease. Next slide. And so that takes us to S1826. Given the efficacy of nivolumab in the relapsed refractory setting, the tolerability of this drug in the relapsed refractory setting, it was evaluated in this patient population in some randomized small phase 2 studies, and eventually translated into this randomized phase 3 study where they had nivo-AVD versus brentuximab AVD for 6 cycles, 1-to-1 randomization, with the primary endpoint being PFS benefit. As you can see, there was a large number of patients, and this was one of the first cooperative group studies that had a large contingent of participation from COG, which is a children's oncology group, as well as all 3 US cooperative groups. Next slide. So this is eligibility. As you can see, patients 12 years and older, HIV positive patients were eligible, and all the rest were sort of consistent with what we expect with inclusion into a clinical trial such as this. GCSF, as you can see, was optional in the patients and not required. Will be a point of discussion later. Next slide, sorry. So with the 994 registered patients, 496 in the nivo-AVD, 498 in brentuximab AVD, evaluable efficacy and eligible patients 49 versus 47, and safety 43 versus 473. And we see the reasons for some patients not being eligible for analysis. Next slide. So baseline characteristics fairly equal between the 2 arms, and we do see a higher proportion of African-American patients compared to some of the other studies, higher portions of Hispanic patients as well in this study compared to some other trials. Very low number of Asian participants, which speaks to this being a mostly North American, well, basically a truly US and North American run study. As we see, majority of patients with stage 4 disease, we see IPS score. Again, most patients 0 to 3, very few patients with high-risk disease, bulky disease, about equal between the 2 cohorts, and small numbers of HIV positive patients. Next slide. Looking at adverse events, as you can see, neutropenia, 55%, grade 3 above, 47%. There was more neutropenia after nivo-AVD because there was more GCSF used with brentuximab AVD. As you can see, 54% versus 95% in these 2 studies. Bone pain, obviously higher because of the use of GCSF. And you do see slightly more grade 3 or higher thrombocytopenia in this patient population with the brentuximab AVD. Next slide. So looking at peripheral neuropathy, as we would anticipate, more peripheral neuropathy with brentuximab, higher grade neuropathy, including peripheral motor neuropathy, not in addition to sensory neuropathy was seen with the brentuximab. And for most cases, grade 2 is typically a debilitating neuropathy in most patients. So you typically want grade 1 only if you have neuropathy. So anything grade 2 or above is a concern in this patient population. Next slide. So other AEs of special interest, you do see transaminitis, fairly equivalent in both arms, rash, again, equivalent in both arms, hyperthyroidism, more in the nivo-AVD arm, hyperthyroidism, more in the nivo-AVD arm, and again, overall low rates of immune-related adverse events in the nivo-AVD arm. Next slide. So more treatment discontinuation was noted in patients with brentuximab AVD. again, mostly from adverse events in this patient population. Refusal unrelated to adverse event was fairly high in the brentuximab AVD, more progressions in the brentuximab arm, death on treatment, obviously high in the brentuximab arm, and more discontinuation of the study sort of experimental agent in the brentuximab arm. As you can see, there's low rates of radiotherapy in both arms, which is an important caveat given the high use of radiotherapy typically in pediatric hematologists when they treat patients with Hodgkin's lymphoma. So this is a key point that they was able to safely eliminate radiotherapy in this patient population, thus hopefully preventing late complications in this group. Next slide. So as we can see, there's a progression-free survival benefit from Nivo AVD, 1 year PFS 94% versus 86% with a p-value of 0.005, hazard ratio of 0.48. Next slide. And the PFS benefit was consistent across all subgroups studied in this trial, again, supporting the use of Nivo versus brentuximab in this patient population. Next slide. So again, we can skip things. This is a duplicate as well. Next slide, please. Next slide. So especially in older patients, so ideally of those who have actually used brentuximab AVD in patients older than I would say 50, you know how difficult it has been to administer this 4-drug regimen in this patient population. This is also illustrated in this trial. So in the US, there was another study by Andy Evans that looked at sequential use of this to improve tolerance. The only downside to that study is it was about a year of therapy. So in this situation, high tolerability, high efficacy in Nivo AVD. And again, these patients are still only treated with 6 months versus almost 12 months if you did sequential therapy with brentuximab AVD. Next slide. Now, if you look at the overall survival in this situation, currently no overall survival benefit. You do see with cause of death, infection 2 versus 4, sepsis 1 versus 2, some other sort of non-cancer related deaths with the brentuximab AVD arm. And as far as deaths from Hodgkin's lymphoma, there was 1 death in the Nivo AVD arm. But overall, 4 versus 11 events. In older patients, as you can see, there's a higher delta as far as the difference between overall survival, 95% versus 83%. Again, related to the tolerability of the regimen of brentuximab AVD, unfortunately, in this patient population. Next slide. So in the conclusion, Nivo AVD improved PFS compared to brentuximab AVD in advanced stage Hodgkin's lymphoma. PFS benefits across all subgroups. It was well tolerated, few immune-related events. Again, important reduction in consolidated radiotherapy, especially in the pediatric groups. And again, as we move forward with longer follow-up, ideally, we'll be able to determine the continued benefit of this compared to brentuximab AVD. And this may eventually become the new standard of care in this patient population, at least in the US or in North America, where we, again, have less use of escalated BIACOP and other regimens using that sort of combination.
All right, a very well conducted study. We'll go back to the CSO checklist here. So Manju, in your practice, that patient population that Taisal described and also the control arm, is that an acceptable standard of care in India?
So regards to the patient population, answer is yes. It looks quite representative of what we see. Though the representation of elderly Hodgkin's lymphoma is a welcome thing here, but still the numbers are lesser if you look at the actual numbers which have been included. Regarding the control, that's not what we practice. When BV became available much later in India, several years after it was FDA approved. And the cost is still very high. So our usual approach remains ROTL approach for using ABVD and dropping glio after 2 cycles or escalating to escalated BIACOP depending on what the interim PET shows. And for younger patients who are, I'm not talking of 12 years, but yeah, relatively younger, but extensive burden of disease in terms of more extranodal site, more bone disease. Many times we, move towards the escalated BIACOP and looking at, 4 cycles of escalated BIACOP, the interim PET is normal. So that's our usual approach. We haven't been very fortunate to get BV early, so not much of discussion on that point. Yeah, thank you.
No, I mean, you're not missing out on much. To Taisal's point, we were never really impressed with brentuximab AVD. We actually in Michigan practice exactly as you do. We still use Rathel for high. I mean, we all just made up who is a high risk patient, right? Whether it's a stage 4, a high IPS, we have no idea. We have no idea what the best surrogate, but we made it up, and we would use HT18 with escalated BACOP, and now obviously BRCAD. So very similar. But I think we can also agree that even though brentuximab AVD is not our standard of care, it is an acceptable, obviously, standard of care, and for many, probably the preferred standard of care. So no derogatory points on those aspects. Is this trial designed to well, let's do surrogate endpoint. Bernie, I know you've done a lot of digging this morning and this week of surrogate endpoints in Hodgkin lymphomas. What did you learn, Bernie?
Yeah, I think it's a good question. There's a really nice paper out of Germany looking at the surrogacy of progression-free survival as a surrogate for overall survival in Hodgkin. And they did both a trial level analysis and an individual patient level analysis. I guess the issue I have with the trial level analysis, they only included the German studies. They didn't include everything else, but that's still a bulk of our Hodgkin lymphoma data comes out of the HD trials. Um, the R squared for the surrogacy for the trial level analysis was reported as good, but I think it was like 0.59, like 0.6, which to me is not a great R squared for surrogacy. The individual patient level analysis was also done and, showed patients that don't progress tend to live longer, but really we want to see trial level surrogacy. So I think it's still an unanswered question of whether PFS is a true surrogate for overall survival in Hodgkin lymphoma.
Yeah, I mean, the North American argument always was, well, it's not, because I would rather use ABVD, get 10% less PFS than BACOP, but know that my overall survival is not going to be any different. So that's always been the argument. So yeah, kind of the jury is still out of how strong of a surrogate marker PFS is. Obviously, overall survival is going to take close to a decade, and we may not even see an overall survival benefit in this study. So is the trial designed to detect or rule out substantial clinical benefit? So the PFS, yes. So I want to talk a little bit about the subgroup analysis, just because there are some sort of teaching points with that. So Teisel showed you the wonderful subgroups of the old patients, and yes, I do believe that old patients should get Nivo AVD. Brentuximab is very hard to tolerate, but when we're looking at subgroups of very small populations, we are absolutely underpowered. And so one of the things that we have to keep in mind is that underpowered studies, not only can you have a false negative, which is obviously what happens most likely because you don't have enough power to show a difference, but you can also have a false positive, a type 1 error. And so, and usually that type 1 error will exaggerate the difference too. So those big, huge curves that you could throw a dump truck through of the elderly population, in real life, if you continue to enroll patients, those curves might get shrunk closer and closer and closer together. So just keep an eye on that when you are assessing subgroup analysis. Obviously, there are, if they weren't stratified for that specific subgroup, there's going to be baseline characteristics that are likely different, but always remember also the power, not only a type 2 error, but also a type 1 error. Censoring. I don't know if you guys saw anything with I didn't. Obviously, OS is very immature right now. I didn't see much censoring at all. New England Journal of Medicine, unless I'm counting all those ticks because they don't report it, I couldn't really fully assess the censoring in that study.
Yeah, I would
Quality of
say
life.
censoring, we couldn't assess. Post-protocol therapy, did you guys see anything on post-protocol? I didn't really see an assessment of that in the supplement or anything else, but that would be something. And I think that was one of the criticisms of the original Echelon trial, was these patients not getting brentuximab upon relapse was a major detriment to that trial in the control arm, in addition to not using sort of a Rathel-based approach. So I think the post-progression therapy, I think, is immature. We don't have that data yet. The quality of life data we don't have yet, but will be interesting to look at. I'm hoping it mirrors the toxicity data, which seems to favor Nivo AVD over brentuximab AVD, but it'll be good. I think it's a good aspect that this trial is looking at that. And they are focusing on these toxicities. So while we don't have a survival difference reported yet, and we won't know for several decades, at least we're also focusing on another outcome that matters for patients, and that is toxicity rates. Anything else you guys noted?
I think
No.
one point which I just want to highlight more from the Indian aspect, that when we use for most of these immunotherapy studies, it's a fixed dose nivolumab. And if you look at even for an adult, the average weight, I'm not looking at 12 to 17 where they really looked at milligram per kilogram dose. This is 18 and above. It's probably this dose is quite high, because the average weight for an Indian male is not going to be more than 60, 65 kg. And for a woman, it's somewhere around 55 kg. That makes it, probably too high a dose. And that brings back to the point, do you need this much? And of course, what it comes with is the financial toxicity. The amount of immunotherapy which is being given, it's practically unaffordable for majority. If we are looking at this kind of a fixed dose combination, not that milligram per kilogram is going to be very, very affordable, but yeah, meaning both from the toxicity point of view as well as the cost point of view, that may be a point which we need to think about when we are looking at patients who are not 80 or 90 kgs and we are using a fixed dose.
That's a really great point, and I don't know. So we started using Nivo AVD, and in the study, they don't report on that patients had virtually any immune-related toxicities. I think there were some endocrinopathies, but we are seeing a lot of hepatotoxicity. So I don't know if Tyson, have you seen that in your practice? Maybe it's just a Michigan thing, but something in the real world, I do think that we might see more immune toxicities than the study has showed. And to your point, it could be dosing, Manju.
I haven't seen the liver toxicity. What we have seen is, unfortunately, a few cases of diabetes, which checkpoint inhibitor diabetes, induced diabetes, is permanent. So there's no reversing it. So that's another point to consider, especially in some of these younger patients. I mean, these patients will have to go on insulin because there is no recovery.
One other point I wanted to make about this study, kind of contrasting it with the prior one too, is this study was entirely written by the authors, by the people who conducted the study. And you can really tell, I think we need to celebrate well-done clinical studies and celebrate studies that are reported in an unbiased fashion. And I really thought this was a well-done trial and a well-reported study in terms of not minimizing toxicities and reporting things, I think, very accurately. So I do appreciate that about this study. And I think as much as we celebrate, we want people to be critical and look at data, we also need to celebrate the trials that are well done. So I do think there are some really positive aspects to this study that we should note.
Totally agree. The other thing that really surprised me in this study is how well the high risk patients, high IPS patients did, how well the stage 4s did. And it really kind of puts up escalated BIACOP of, hey, maybe we don't need to be using a more intensive regimen for that group because we're not losing 20-25% of the patients anymore. I think the progressions were maybe like 10% or so. So that all being said, let's summarize all these studies and then we can take some questions. But Tyson, how are you now applying SWOG and how are you now applying STARGLO in your practice? And then we'll get Manju next.
Yeah, the SWOG study is probably a bit easier. I think for the most part, that's sort of replaced ABVD in most of the patients. As you mentioned before, AAVD was harder. As far as STARGLO, hasn't really impacted the clinical practice just because, again, to Manju's point, auto sort of ineligible is never really the question anymore for most of these patients. I mean, I think that is a, very much 7 years ago sort of division of patients. So with the relapse patients, there are a multitude of options that ideally induce good clinical response. And I don't necessarily know if you actually need Glofit and Gemox in that patient population, at least in the US. Refractory patients, again, the goal is to get them to CAR T. Now, if you need a bridge to CAR T, maybe this may make a good option, but um, I do think for the most part, STARGLO hasn't really changed anything that I would plan to do in my clinical practice.
So I agree with Teisel. We do come with an additional level of affordability, which becomes a challenge. And if we look at patients who are in this category, and if they're transplant eligible, not refusal of transplant, if they're truly transplant eligible, then that becomes the treatment option. And if we look at the total cost of 12 cycles for glofitamab, it turns out that the CAR-T, in at least our scenario, what is available to us is cheaper than glofitamab. Glofitamab is still not marketed in India, so that becomes another layer of complexity which comes in. It requires an import on an inpatient license basis. So between all these choices, I think if this is a subset of patient where they're eligible otherwise for transplant, salvage and transplant, if they have access to CAR-T, then CAR-T becomes the preferable choice. So that's what my take on that would be.
Excellent. We can open it up for questions now. There were some questions in the chat. So do you give GCSF for all patients with Nivo-AVD, despite the low rates of febrile neutropenia? Tyson, in your practice?
Typically, no. I mean, I sort of mirror like we did with ABVD, where, we would just ride out the neutropenia just because the patients generally never get sick, which is quite different from what we saw with brentuximab.
Yeah, we don't either. It wasn't mandated in the protocol. They added it if needed, but yeah, we virtually never add it. Do you wait until after all 6 cycles to get a PET or ever consider escalation like BRICAD?
So I think we still are very beholden to PET2, even though we know that doesn't really have much of a PFS sort of outlook anymore. But I do also think escalation of that regimen to anything BIACOT related has really never shown a substantial benefit. So generally in those situations, if the patient were to progress, I think you're trying to get that patient to an auto transplant is usually the most logical step. So I'm not sure what Manju would do in that situation.
Yeah, so we use a very few Nivo-AVD as of now. So, but I agree with Tyson that we still have not left interim PET completely because this is a group of patients where you feel worried. But at the same time, we do need to look at the interpretation of PET in these patients because of the pseudoprogression and the immune response which you get and which can result in false positive PET. So definitely, if we are thinking in terms of end of therapy, disease persistence, which is basically PET positivity, biopsy, and then plan for any further change in therapy, just to make sure that we are not handling a false positive PET. Considering escalation, we haven't used BRICAD in our setting till date. Yeah.
And then follow up about the immune-related toxicities. Can you explain any reasons behind the low immune-related toxicities? I think some of it just has to do with it's coupled with chemotherapy. And when you see, even in other disease states, when you couple PD-1 inhibitors with chemo, it seems to abrogate some of the overactivity of T cells. I think that's just the only rationale I can think of, unless the other group members know.
No, I think I'd agree with you. I think it's just the chemo effect.
We also have short follow-up for a lot of these things. So I think we'll learn more and more as we expand this to different patient populations too and use it in the real world. I think we'll hopefully learn more.
Yep. Then a clarifying question. So BRICAD, I absolutely agree. BRICAD has phenomenal PFS at 5 years. I think it's still a population we strongly consider in our young patients that are high risk, but we still sit down with them, show them the numbers, and it's still we tried to convince a patient this week we were very worried about, and they ran for the hills. They're like, no, I'm never touching BRICAD after you talk to them about the side effects. potential for secondary malignancies. And I think 4 years is still too short to know if you're going to get a deletion 5, deletion 7, which is going to happen 5 to 7 years later. And so I don't know the secondary malignancies if that's going to shift the delta of the PFS. That's only what, like 5-ish% now. Is the secondary malignancies going to take over? I don't know. So, but both are very appropriate options that we have to talk to patients about.
Yeah, I think the shortened therapy is maybe an advantage, but I think a caveat being, you had talked about, the SWOG patient population. This was a pretty high risk disease population, and you could argue even more of a high risk disease population than HD21 that looked at BRCAD, which is not what you'd anticipate considering how toxic that regimen is. So I think it's hard to kind of cross trial compare all of these.
For sure. For sure. Comment about only 2 out of every 10 patients eligible in the US will actually make it to CAR T. It's sobering stat, that's for sure.
Well,
I think
also, but part of that issue is, again, it's a referral issue, and the fact that majority of these patients are in the community. And so I think by the time they get referred, it's that issue. But we've also had difficulty with uptake of bispecifics in the community too. So I think it's an overall just general issue of lack of adoption to some of these newer therapies.
Next question. Would a subgroup analysis be valid, powered enough if there has been pre-specified stratification? I think if you have powered the subgroup and you did pre-stratify the patients, so you essentially have like a randomized controlled trial within a randomized controlled trial. I think it gives a lot more strength to that subgroup. Absolutely.
Yeah, the one caveat is the more times you assess something, the more times you are to see something just by random chance. And a great example is the ISIS-2 trial of like streptokinase and aspirin, where they asked for like a bazillion subgroup analyses. And this was a cardiology trial, so it had thousands and thousands of patients, so they could do it. But one of the subgroups that was significant was like astrological birth sign. So to just show you that the caution of using these subgroup analyses, because the more and more things you look at, the more and more by random chance you could find something. So they also have to control for multiple looks at the data.
Yep. Great point, Bernie.
All right.
I applaud them for not using medical writers. Anybody notice how the articles are getting shorter and shorter and everything's being forced into the supplement? Yes, and it makes it very hard to critically appraise. I completely agree.
Yeah, the other thing that we didn't talk about, just really briefly before we tie it up, one of the things that we'd like to see as a CSO group is more lay language summaries for patients. We're talking about these studies to patients, but I do think the public would benefit from lay language summaries of all of these trials. So I would love to see that happen more in the future.
Yep. And I'll just answer one last question here. Is what would you give a patient that has relapsed after Nivo AVD? Tysil, your thoughts?
So these patients surprisingly still respond very well to salvage. I think this is best exemplified in the Pembro GVD study where we didn't talk about this, but they tried to do Pembro GVD with just maintenance Pembro, and these patients relapsed were still salvageable with bendamustine-based regimen, and all of them did very well with an auto transplant. So these patients still seem to be very sensitive to chemo even after failing a checkpoint inhibitor, and you can still get them to an auto transplant, which is still curative in this patient population.
Yeah, our practice would be ICE or bendabrintuximab followed by auto. But it's a great question because we don't really truly know what the right answer is. Manju, any other thoughts about that?
I think the other point we need to keep in mind how long they have relapsed, whether we are talking in terms of primary progression or somebody who's relapsed, let's say after 18 months, they would still be sensitive and you can re-challenge. And of course, brentuximab plus chemo always remains a choice in this subgroup.
Well, I want to thank our experts for joining us tonight and thank everyone in the audience for coming and asking great questions. Reminder, next month we'll have another one of these focusing on a solid tumor topic. And so hopefully many of you can join and join in the discussion. Brian also posted a link to the RCT paper. If you want to take a look at that, it's a free download, I think, via that link. And if you have any questions, reach out to one of us. But I really appreciate everyone joining. Thank you all.